So here we go. This is part 2. Finished the diffuse process, and now we're going to move on to some focal disease. First case, remember, here's the strategy. What's the gamesmanship? What are the sequences? What's the cut through? Why are you showing me this? So we have an axial T2 through the liver. We definitely know it's a T2. I can see that CSF. And then we've got thick cut MRCP also through the liver. So we got a bunch of T2 bright things, sort of look like they might be cysts. They gave us an MRCP, and so anytime you see an MRCP, obviously they want you to look at the biliary system. If they just wanted you to look at the cysts, they would not have shown you the MRCP. You can see the cyst just fine on the regular axial T2. The MRCP is for looking at the ducts. And when you've got a bunch of cysts in the liver, the number one question in your mind should be, do these communicate with the ducts? And if they're going to do it multiple choice and show you a single slice, they have to make it obvious that they are indeed. And this isn't obvious to me, so I'm going to say they're not. And if they're not, that means that they're von Moyenberg complexes, which basically just means they're a bunch of hamartomas. So what if they are communicating with the duct? So let's look at the sort of classic this versus that. Over here we've got the case that we just saw with a whole bunch of cystic looking things. And then over here, another T2. It looks like they're you can see right there. They show me a picture where it's communicating with a duct. Look at that right there. That's communicating with a duct. They showed you that. Of course they did. They had to. Otherwise, you can't tell the difference. The other thing they could do is just not put von Moyenberg complex on the list of distractors. That would be another strategy. But I would think that they would show you the duct. So here again, MRCP. This was our case that we saw before. Here, where it's not definitely communicating with the duct, and here it very obviously is. Very obviously coming off the duct, right? There you go. So the von Moyenberg complex do not communicate with the duct. They believe in nothing, Lebowski. And Caroli's definitely does communicate with the duct. In fact, this is a type 5 choledochal cyst, right? Here's our companion case. We've got a CT study with contrast through the liver. With a close look, you can see that you've got your central dot sign, this thing right here. And that is the classic look for Caroli. So what are the associations that you need to know? So it's still a bunch of cysts, right? So you can think about polycystic kidney disease, and medullary sponge always sort of get its way in there also. How do you remember how they show medullary sponge kidney? Remember that? That's your medullary nephrocalcinosis case. It's usually unilateral. This is the one you have to remember, cholangiocarcinoma. And the way that I remember this is you've got abnormal ducts, so you've got stasis. Bile is dirty, so it creates a lot of inflammation. Inflammation equals cancer. Cholangiocarcinoma is your duct cancer relative to hepatocellular carcinoma, which is your parenchymal cancer. Next case, remember, what are you showing me? Why? Why are you showing me? Why are you showing me these cuts? What's the sequence? It's a T2. We've got an axial. We've got a coronal. It's a T2 because you want to show me something that's T2 bright, like a dilated duct. And there definitely are dilated ducts, right? Here, this is really abnormal. That's abnormal. So when I see this, I think to myself, all right, it's going to be some kind of a biliary process, or it's going to be a cholangiocarcinoma causing obstruction. Can't for sure tell the difference here. Now, when you get the dreaded ERCP case, it's actually helpful, or a really good MRCP. And what you're seeing here is the withering tree appearance, where you've got interposed normal ducts and beating. A cholangiocarcinoma is not going to do that, right? It's just going to clamp down and dilate everything. This is actually a process that's intrinsic to the ducts, and that's how I tell the difference. So what do you need to know about primary sclerosing cholangitis? It actually favors men. Most biliary conditions are female predominant. Because it's an opposite of the normal trend, I think that makes it a testable thing. Also, and I believe I mentioned this before, but if I haven't, I'm going to mention it again. Anytime gender shows up or race shows up in the question header, it's showing up for a reason. So if they're specifically telling you that it's a man, it's helpful to think that this could know that it's more common in men, because it's actually a hint. They're being nice. They're being nice to you. I don't think that trickery will occur with regard to demographics. I just don't believe that they'll do that. They may just omit the demographic, but I don't think they would deliberately mislead a demographic. Like, for example, giant cell arteritis or temporal arteritis. That occurs in old people, right? Almost always in old people. They're not going to tell you the person's 30 or 25 and then it be a giant cell case. Yeah, it's probably case reported somewhere that could happen, but it's either the age is going to be omitted, or they're going to tell you it's an old man. I think it's the same thing generally across they're not going to show you Takayatsus and tell you that the person is white as opposed to an Asian, right? They're not going to show you a spin tumor in the pancreatic tail and then tell you the person is white, when that's more common in Asians and African Americans. So I do think that it's helpful to know some epidemiology for the purpose of picking up those hints. Now this is the actual question. If you were going to get an association question, this would be the one that I would think they would ask, because it's the one that they always ask on step 1, right? It's the high yield correlation, ulcerative colitis with primary sclerosing cholangitis. And of course, increased risk of cholangiocarcinoma. Inflammation, bile duct inflammation, cholangiocarcinoma. So what do you need to know about cholangiocarcinoma? It's bad. It's very bad. You're completely fucked if you can't cut it out. So what makes it unresectable? Involvement of the secondary order radicals. Well, what's that mean? That means when they branched a second time. Main portal vein encasement or occlusion. And then opposite side vascular involvement. So artery on one side, portal vein on the other. The other thing that I think is worth knowing is the quote capsular retraction. So they usually, in most books, if they show cholangiocarcinoma, they show it in the hilum as like the Klatskin type. But you can also have peripheral subtypes of cholangiocarcinoma, and that's sneakier. And the classic buzzword is capsular retraction, a nonspecific entity. But if you see capsular retraction or the word capsular retraction, I would circle cholangiocarcinoma on the test. All right, ultrasound case. So we've got hyperechoic lesion in the liver. And probably everyone who's looking at this is going, it's a mangioma case. It's a mangioma case. It's always hyperechoic lesion equals a mangioma. I'm here to tell you that is not, you got to be careful with that. You got to be careful with that in real life, and you got to be careful with that on tests too. Because hyperechoic lesion in the liver means absolutely dick. That could be a met, that could be a cancer, that could be anything. Yes, hemangiomas are common, but that is not at all a specific imaging finding, because it's hyperechoic relative to the liver parenchyma, and the liver parenchyma can be all kinds of different. So you call them back for CT. And this is a sneaky case here, guys. Sneaky. So we're seeing peripheral arterial, nodular, fairly discontinuous enhancement. But it's sort of heterogeneous in the middle there, right? It's not supposed to do that. It's supposed to look like this one. All right, so this was our case. This shit's not supposed to be here, man. That's not allowed. You can't have that in there. This, that. You can't have that. The stuff on the outside's okay. So here's a hemangioma, right? That's all right. That's cholangiocarcinoma. It's not always at the hilum. It's not always at the hilum. Remember what I said also. You gotta look out. You gotta look out for this right here. You get some capsular retraction in there. You gotta look out for that. But that would have been too easy if I showed you capsular retraction. That'd have been too easy. I'm getting sneaky here. All right, so what about this one? That's big and scary, right? Non-con study, then contrast. Looks like it's got some peripheral nodular discontinuous enhancement. I'll bet you if you've got a delay, that might fill in. So what are the kinds of hemangiomas? So hemangiomas come in three flavors. Three flavors is how I think about them. They come in these flash-filling types, where they are obviously not dense on non-con, and then they get bright and stay bright. Then you've got sort of the more classic look, where you've got peripheral nodular discontinuous enhancement that progressively fills in, follows blood pool. That's this one. That's the one everybody's sort of familiar with. And then you've got these big, scary-looking guys that can be massive, and they often have sort of a central-looking scar kind of thing to them. It's nice if you get like a 10-minute delay on this. If you had a next step question, it'd be like, I want a 10-minute delay. The tech is called from the scanner and is already told the patient they have cancer. And so they want to know what to do because the patient is crying uncontrollably. And you keep them on the scanner and you do like a 10 or 20-minute delay. And then it should fill in completely, iso attenuating with the liver, and then you know that it's a big cavernous hemangioma. So what about this guy? Remember, what's the strategy, guys? Deep breath. What's the sequence? What is a target organ or lesion? Looks like this is a non-contrasted study, and this is CT, obviously. And it's through the liver, which is super duper fatty looking, right? And then we've got a bright lesion on a fatty liver. And this is what I was trying to get at with ultrasound, is that you got a fat liver or a really heterogeneous liver from whatever, that you're hyperechoic or hypoechoic, that's all relative to your background parenchyma. So you get a conventional contrasted CT, and it's a hemangioma. Just on a fatty liver, it can look crazy. So family medicine doesn't believe you. Is there any other test that you can do other than an MR? And you can get a tagged red blood cell scan, right? I've seen it done. It's a thing. Nuclear medicine tends to show up in this kind of... this is the utility of nuclear medicine in the real world. All right, next case. Well, you sort of get the feeling there might be a lesion in there, but it's kind of hard to see, right? Some people might even say it was a stealth lesion. And then on contrasted, so here we go. What do we got? T2, T1, post-contrast. It's enhancing homogeneously, right? Got a central scar. Here's another, this is a companion case, different patient. Again, sort of ISO intense, right? ISO intense, T1 and T2. And then on your delayed EOVIST, this would be marked like 20-minute delay or 15-minute delay EOVIST. It's totally ISO intense to the background liver parenchyma, just like blends in. And there's really only one thing that does that, right? Well, maybe. We'll talk about that in a second. So what do you need to know? That central scar, what signal is it? Yes, I do know what signal it is. It's bright versus the fibrolamellar HCC, which is classically dark. It enhances late, like a scar does. If you know any cardiac MR at all, you know that is a principle, that scars do enhance, typically later. It retains eovist on a delayed scan. And at one point in my life, I thought that this was the only thing that did that, which isn't actually true. But on the exam probably is. So delayed eovist is confirmatory for an FNH. Just put that in your head and that will be fine. But know that a well-differentiated HCC can do that as well. So how does eovist work? So here is your hepatocytes and your bile ducts. And you've got these transporters, these OAT-P bile uptake transporters. And these are the guys that are responsible for bringing the eovist in and letting it get pumped down into the bile duct. So as you probably know, as a cancer forms in the liver, it preferentially changes the thing that it prefers to drink from portal venous blood to arterial blood. But another thing that happens during this hepatocarcinogenesis is a decrease in this OAT-P transporter. It goes away. And then you end up not being able to get the eovist in, right? And that's why an HCC is going to be a dark hole on eovist. Well, what are some other things that are going to be dark holes? Cysts. Basically anything that's not a normal hepatocyte that doesn't have this transporter. But since an FNH is basically hypertrophy of normal hepatocytes, you would expect it to retain that and act like normal background liver parenchyma. But if you have a very well-differentiated HCC, it's still sort of acting like a normal hepatocyte, and it can retain that OAT-P transporter and continue to put eovist into the bile duct. So you can get, that would be an exception to the rule. Remember, exceptions to rules are highly testable. So family medicine doesn't believe you. They don't believe anything. These guys just don't believe you. Is there anything else you can do? Sure, right? You can do sulfur colloid, but remember with the sulfur colloid that like 30% of the time it's hot, 30% of the time it's cold, and 35% of the time it's iso-intense to the liver. So it's really a bullshit test, but it does end up often showing up in case books and all kinds of case conferences. Lots of people love to ask this. So yeah, it's a thing you can do. And occasionally it's helpful. All right, what about this thing? It's a big mass, right? Big mass in the liver. All right, so they were nice enough to give us an MR, and it's a little blurry down here, but I'm just going to tell you that on this in and out of phase imaging, remember, what did I say on the first lecture? In and out of phase imaging, anytime you see that, it's a fat question. So what are your fat questions? Adrenal adenoma, hepatic adenoma, and then focal fat sparing or infiltration. Those are the main four that I would know for abdominal imaging. So can't see the adrenals, and we got a big mass. So if that shows signal dropout, then I'm going to call that hepatic adenoma. That's a classic way to show that. So there's actually a couple different subtypes. You have the ones with fat, and they like to show this on in and out of phase imaging. Okay, you've got the ones that bleed, the inflammatory ones, and these are the ones that are going to have like a subcapsular hematoma, non-cirrhotic. Remember, if you see a big bloody mass, you got to think HCC. But so a big bloody mass in the liver of a cirrhotic is an HCC. A big bloody mass and like a young person on birth control is a hepatic adenoma. Portal vein thrombosis, spontaneous. You got to think about HCC also, especially in a cirrhotic. So why do they, or can they turn into cancer? And the answer is yes, they can. It's rare, but that's the reason that they'll actually cut them out. That and the risk of bleeding. What's the most common location? Just visually, remember that case I showed? It was in the right hepatic lobe, right? Subcapsular location, and they're almost always there. And what's the classic history? It's somebody on steroids or somebody on birth control. And what about if they're multiple? That's a glycogen storage disease. Okay, moving forward. All right, so T2 and T1, windowed super duper tight. It's actually easier, I think, to see the lesion here on the T1. And then once you find it on the T1, you can look back and notice that it's there on the T2. So we've got this versus here, where we've got a T2. Here it's T2 bright. And then a T1 post-contrast. So we'll get back to what that is. Let's just take a minute and talk about how cancer forms in the liver. So just like a first-year resident, you start out happy. You're not taking any call. You think radiology's easy because you were told that it was supposed to be easy. And it's way better than your fucking surgical internship that was a huge waste of time, right? So you're just happy to be done with that. But then you progress, take a little bit more call. Attendings are mean to you, calling you a trainee, making you do scut work. And then you start studying for the core exam. They won't give you time off. You really start to hate the place. So that's the same kind of thing that happens in the liver. You get insults, you end up getting abnormal, and then become progressively more abnormal and splastic, and then you turn full into a cancer. So here's the thing I want you to remember about this, okay? So the dysplastic nodule, if you look, you see this is a super variable, right? But what's not variable is this. T2 bright. These guys are T2 dark. T2 bright is a cancer. That's your take-home point. So that means this is a cancer, right? Prometheus, you just told me that a T2 bright thing in the liver is a cancer, so I should tell this guy he has cancer, right? We should biopsy that cancer. No, that's not what I mean. I don't mean. So T2 bright, like really bright, like bright as CSF, that's not a cancer. That's a cancer. This is your so-called evil gray. So that is the kind of T2 bright that is a cancer. The gray kind of T2, not the bright kind of T2. So family medicine, again, they want to get a PET. They've read that PET is good for cancer, and they think that they should get a PET for this guy with HCC. So it's terrible, right? It doesn't help. I read somewhere that the reason that it doesn't work is, like you bring your glucose, your tag glucose molecule in, and it gets phosphorylated, and that traps it in the cell. HCCs actually have a thing where they dephosphorylate the glucose, and it does so it just floats right back out. I read that somewhere. I can't remember where. It might be a black pearl. However you want to remember it. Basically, HCC is not real good on PET unless it's really big and really high grade. It does typically do okay with METs, but it would not be the test that I would use to sort of confirm whether or not that a lesion is indeed an HCC or not. If you can't figure it out and you're still suspicious based on MR, CT findings, then I would biopsy the motherfucker. Okay, moving on. All right, I love this case. So it's a bunch. So it's an MR case, right? It's a contrasted case. You can see the contrast in the aorta, and you got a whole bunch of enhancing things in the liver. The liver otherwise doesn't really look cirrhotic, though, and that's a bunch of HCCs or METs or something. You're like, okay, this guy doesn't have a history of METs. But I'll tell you that you can't see his hepatic veins. Well, scroll up and down, and we'll tell you he doesn't have hepatic veins. They're out. So this is your Budd-Chiari case. And there's 3 ways to show this. Okay? There's 3 ways. You can show hypertrophy of the caudate lobe, which is probably the most classic. Remember, the caudate lobe has a different venous drainage, so it gets spared and then hypertrophies relative to the rest of the liver. You can show this, the flip-flop perfusional pattern, where normally the periphery of the liver enhances early, and then the central part sort of comes in a little bit later, and this is the opposite, where the drainage is all fucked up for the liver, so you've got central enhancement first. And then this one, your Budd-Chiari nodules. They have to tell you that there's Budd-Chiari though, because this could be islet cell mets, renal cell carcinoma mets. At some point, they would have to show you an ultrasound with hepatic veins out or something. All right, what about this guy? So this is a classic nutmeg appearance of the liver, which, you know, has a differential, right? There's a differential. Budd-Chiari is on that differential, but it's usually right heart failure, right? That's much more common. And to prove that, it would be nice if they'd show you something like this. Reflux of contrast into the hepatic veins on a PE study, right? You probably have seen this. Or it could get real sneaky and show it on an ultrasound with really dilated hepatic veins. Next case. So this is really critical in gamesmanship here, guys. Pay attention. Axial CT, non-contrast. Axial CT, contrast. So this dent, there's a bunch of dense stuff in the liver on the non-contrast, right? So this is your rocky liver. There's a differential for that, but you have to think of one thing first, and that's mets. So what kind of mets? Where would the mets come from? Remember that mucin calcifies. So adenocarcinomas that are mucinous, any kind of other mucinous tumor, is going to create this appearance of calcification. So calcification in the liver is colon cancer mets until proven otherwise. Unless you know there's a mucin-forming tumor in another place in the abdomen, and that's probably that. And another really good point of trivia with regard to calcification in the liver is that although HCCs can calcify, the fibrolamellar HCC is much more common as far as their calcification. Fibrolamellar tumors are rare as fuck, and they almost never ever happen outside of tests. And remember, this is a young person who's non-cirrhotic and has a central scar, but the central scar is not T2 bright, it's T2 dark, and it's not going to behave the same as an adenoma or an FNH on Eovist. How about this guy? He's got some high-risk behaviors, this guy does. But he likes to have fun. So that can be, so we got a whole bunch of hypoattenuating lesions in the liver, really bad juju in the liver here on ultrasound, this target sign. So that can be a whole bunch of stuff. Infection. Could be cancer also. This could be mets. But the history was leading you that this guy has got infections. Remember, there's a whole bunch of stuff that you can get in the liver, and it's hard to tell the difference. All right, how about this one? It's a great case. So, T2 through the liver, all this stuff, right? What's that? What is that? It's edema, right? And it's periportal edema. That's what that looks like. So, periportal edema, and you didn't show me the IVC being really big. You're not showing me the heart. I was like, why do you have periportal edema? So, on a single cut only through the liver with no other explanation, you need to think about hepatitis. An enlarged liver also, and the other way that they like to show hepatitis, classically in case conference, and very likely on multiple choice tests, is that thickened gallbladder wall, right? The gallbladder edema. Just think about the liver having a lot of edema and being swollen while it's dealing with its itis. All right. So here's a trivia question. HCC typically occurs in cirrhotic livers, right? Is there any situation where a non-cirrhotic adult, remember I mentioned adult here, right? I'm not talking about fibrolamellars, that would be in a kid. So an adult non-cirrhotic might get an HCC. And this is, I'm specifically want to know if there's any kind of an infection that can cause it. Non-cirrhotic now. Yeah, so acute hep B can cause an HCC. All right, here's a good one too. This is sort of a classic. It's a good case. So this guy, this hyper-enhancing lesion right here. That location is classic. And here we go. Here's some other stuff that's going on here. Huh? Look at that. What about that? So this is your hot quadrate sign. They love this stuff. So basically this means there's been SVC obstruction, like from histo causing median stenitis, sclerosing median or fibrosing median stenitis, or a big lymphoma wrapping around the SVC, or scarring from a central venous catheter like this one. So, but it's a sign of SVC obstruction, and there's a complex collateral pathway that no one knows well enough to ask. It'd be completely unreasonable to ask you to like detail that pathway. All right, what about this one? So I've given you the history that this patient's had a liver transplant. All this post-op crap going on here. And then right through the center of the liver, along the bile ducts, there's all this dark stuff. It's bad. Biliary necrosis, right? So why does that happen? Where would you look next? Well, it's a liver transplant. You always want to look where first? Hepatic artery, right? You want to look at that hepatic artery. That hepatic artery, you got to tell if that thing is patent. That's the one that matters. So in a normal liver, you have a dual blood supply that's like 60-40 or 70-30, depending on what you read. Portal vein dominant, hepatic vein non-dominant, or hepatic artery non-dominant. In the transplanted liver, the hepatic artery is the most important player, and that's your main blood source for your bile ducts. So if you lose your hepatic artery, you end up with bile duct necrosis, and you end up with biliary abscess later on. So let's review real fast some transplant stuff. Normally, you want this. You want a brisk upstroke, and you want some diastolic flow, but not too much. Now, and these are your sort of your RI. Now, elevated diastolic flow is very sensitive, but it's not specific. And I think about this as like the liver is hungry. It's hungry, and it needs more flow. So instead of just getting blood flow during systole when it's pumping, it needs it all the time. It's hungry. I'm hungry all the time. It wants to eat all the time because it's basically been put on a diet because it's got narrow, the vessel's narrow, right? So it's during systole, it's not getting as much as it wants. So it cries out for help, and it drops its intrinsic resistance, increasing the diastolic flow. So that's a sign of increased diastolic flow is a sign of a hungry or thirsty, very thirsty liver. So that's a very sensitive sign. Remember, early on, though, that can just be from edema. Now, once you have this, where you've got a blunted upstroke, you've blunted your upstroke, and you've got increased diastolic flow, this is a very specific sign, and that means that you've got, I would call stenosis on that. 6 days a week and on Sunday. So here we go. Hepatic artery down, bile ducts hurt. All right, so scrolling case here. A bunch of weird tangly vessels. Look at that one right there. A lot of weird tangly vessels in the liver. So when you see that, what are you thinking? There's only one thing that does this. So you see that. Where do you look next? Where do you look next? You look in the head, right? Look for the brain abscess. This is HHT. So this is the guy with the bloody mouth, the bloody nose. He can have a bunch of lung AVMs also, and that's why he's getting these shunts to his brain. GI bleed is a classic history. There's nothing else that looks like that. It's an Ant Mini. All right, well, what about this one? Ooh. Ooh. Pregnant. What's this? What's that? That's not supposed to be there. Alright, so remember this? This is like third-year med school stuff. HELP syndrome. So this is a subcapsular bleed, right? That's the classic appearance. Who gets this? Remember who gets this? It's young people, first pregnancy, third trimester, right upper quadrant pain, preeclamptic DIC. It's bad news, right? But the imaging finding is to show it as a subcapsular hematoma. All right, so we're done. That is everything I got on the liver. I think that that's pretty much everything you need to know. And the next talk is on the kidneys. And the overlap, I do some overlap with some GYN malformations that are associated with kidney stuff. So stay tuned, that's coming up next.